Well, hello again, human biology class. Here's attempt at circulatory system video lecture number 2. Clever name, huh? Yeah, last time we talked kind of towards the end a bit about the electrical stimulation of the heart with the SA node, the AV node, Purkinje fibers, kind of how that happens, how it progresses through the heart as a beat occurs. All that, remember, that all happens in less than a second. And of course, there are a number of issues that occur when it doesn't happen correctly, and some of those issues would be if in fact this particular description, if you will, of the heart doesn't occur like it should. And so this is out of an EKG or an ECG. EKG stands for electrocardiogram. It stands for ECG stands for electrocardiogram too. It just matters if you pronounce cardio with or spell cardio with a C, or like in Germany with a K. Same thing. And all this is not a physical representation of what goes on in the beat of a heart, or in a heartbeat, but rather this is a representation of what's going on electrically when a heart beats. And so there are these different parts: a P portion, a QRS portion, and a T portion, ST portion. Okay, so this is broken down. Here you have the P wave portion. That's atrial contraction. That's when the two little chambers at the top of the heart contract. So that's when these two chambers of the heart contract. The QRS portion is when the ventricles contract. And then this segment, the ST, that's the beginning of, and here, the relaxation of the heart before the whole thing starts all over again. The particular heart attack that I had was called a STEMI, STMI, ST elevated myocardial infarction, hence the name. And so this section of my ECG was elevated, was up here, and that told them right away what was going on, that I was having a heart attack. And so you'll see a number of things that can be diagnosed with an ECG or an EKG. And here's some examples of some other items. Common heart rhythms. Okay, so this is what a normal rhythm would look like, with a P, Q, R, S to a T. Okay, and sinus tachycardia. Tachycardia means too rapid of a heartbeat. And the sinus rhythm, okay, you can see how fast that's occurring compared to here. A bradycardia is too slow of a heart rate. And again, you can see that exemplified by the span between each QRS wave. Atrial fibrillation, AFib as it's called, that's a fluttering of the atria. And so here you can see that P wave really isn't showing up at all. And I'll maybe show you some commercials that talk about medications that deal with AFib, because the deal is this, folks. If the heart if the heart malfunctions in any of those ways, if blood sits in any of these chambers for even just a small amount of time, it's prone to clotting. And a clot then can plug any of the vessels that go to the heart, or maybe go to the brain and cause a stroke, or go to the lungs and cause a pulmonary embolism, which we'll talk about when we get to, all those things we'll talk about when we get to those sections. But so we don't want blood sitting around. That's a bad deal. And so that's the main risk with things like atrial fibrillation. If this chamber doesn't contract correctly, it might not push all the blood down. It might sit in there long enough that it can actually clot. To deal with that possibility, people will have pacemakers put in. And here's an example of a pacemaker. Okay, you can see how big it is. This is an actual one, and it would be placed here in the upper shoulder region. There would be leads here. I have some of those leads. It's hard to see them, but they're small. This is what they would look like. And they would go into the pacemaker, and you can see them strung through the body. And I think this one isn't used. I think this one is probably just going into the lower ventricle of the heart in this particular case. But there's lots of flexibility, lots of options. But that's how that would work, and it would help regulate or normalize a heartbeat. There are other items that humanity has come up with to deal with problematic hearts. Of course, in the past we've had, well, I got to move me up out of the way here. Sorry. In the past, we've had people that have actually had artificial hearts. These were actually developed, jeepers, I think way back into the 70s, or 50s, I mean. In 1983, one was put in a person named Barney Clark, and he lived for 112 days. Imagine that. Here's a guy that's alive, but he doesn't have a heartbeat. These don't produce a heartbeat. They're just a simple pump that moves blood, but they do so mechanically. The record was a guy named Bill Schrader for, what do you have? 620 days. He had an artificial heart in, but they don't last forever, and both of those people died. And some of the complications are, whenever you put something mechanical, artificial in the body, it's an infection site, a huge infection site. And that was the case with both Barney Clark and Bill Schrader. I think they both died of infection, if I remember right. The other problem is these artificial pumps aren't nearly so nice on red blood cells, and they wear out more rapidly, just get beat up in the pumping process. And so now we don't really see artificial hearts thought of as a replacement for a heart, but rather they're a bridge to transplant. So they'll be put in a person that's waiting for a transplant heart. Or maybe somebody's having heart surgery, and so they'll be put in the person as a bridge to get them through the surgery, if you will. Then more common recently would be something called left ventricular assist device, LVAD. And if we look at these, this is what one might look like, and you can see there's battery packs here and there. They're attached to a device that goes into the heart. And inside the heart, this is what's going on. They are actually down here to the left ventricle, and there's a pump here that's helping that ventricle push blood more effectively. And in a person, this is what they might look like. They're fairly out of sight, and it's pretty incredible what people can wear around that helps them, get through their everyday life that we might not even notice. But these are all devices that are used to help the heart out when it's not beating effectively. Okay, so if we go back to the notes, that was all right about, we left off right about here. And so I wanted to just pick it up right here. Each heartbeat pumps about 75 milliliters of blood, is what the notes say. And so if you think about what that looks like, I don't know if you can see this well with this camera, but right there, that's about 75 milliliters of blood. That's what gets pumped on average each time the heart beats. Just to give you an idea. Cardiologists will pay attention to something called ejection fraction. How much of the blood that's in the heart actually gets pushed out of the heart each time it beats. And just so you know, they want to see 50% or higher leave that chamber of the heart each time. If it doesn't, then it gets pushed out the next time. Remember, blood can't sit anywhere, or it's person becomes at risk of developing a clot. Well, the heartbeat generates blood pressure, and it does so at the rate of about 120 beats, 120 over 80, about 120 psi over 80, or not psi, but millimeters of mercury over 80 millimeters of mercury. 120 over 80 is what we're looking at. And basically, that's the pressure it takes to push that very heavy liquid metal mercury in a tube of a given size, a given distance. So heartbeat about 120 over 80, on average. That first number is the systolic pressure, and that's the pressure that is generated when the heart beats. Okay, when these chambers contract in the vessels, typically measured in your arm. You've had a blood pressure cuff put on you, I suspect, and so that heart is pushing that blood hard enough to cause basically that much mercury to be raised well, basically 120 millimeters of mercury of pressure in the arm at a time. The diastolic pressure would be after that heartbeat. Then when the chamber is at rest, when the heart's at rest, there's still pressure in the system, and that's because the system is elastic. If I take this tube and I stretch it, okay, I can also stretch it this way. Okay, and this is like an artery, and I'll demonstrate this in class when I get the chance. Or if I was to blow on it and it really had good lungs, it could blow this up. There would be flex in the tubing that's carrying the blood, and so when the heart beats, you could picture this tubing swelling up as that pressure pushed blood through it, and then when that pulse passed, the tube would contract, but it wouldn't contract completely because there's still a lot of fluid in the system, and the next beat is coming. And so these elastic walls help retain some pressure in the system, even when the heart isn't pumping. We would call that diastolic pressure. So systolic pressure and diastolic pressure, 120/80 is the average. We're going to do this in lab after break, and many of you will have blood pressures lower than that. You'll be all worried, oh no, my goodness, am I going to die? Actually, no. Actually, blood pressures lower than 120/80 are good. They're healthy. Now, you can have low blood pressure, certainly, and that's not good either, but not as bad as high blood pressure, but not good. And when we get to the kidney, I'll explain why that's the case. You have to have a certain blood pressure in the system or bad things happen. Maybe I shouldn't have said low blood pressure isn't as bad as high blood pressure. That I shouldn't have said. High blood pressure is more commonly a problem than low blood pressure is. Maybe that's a better way to say it. My wife and I kind of keep track of sort of the records that she encounters at work. Of course, no names, but her current record for worst blood pressure that she saw in a living person, because dead people usually don't have blood pressure. The worst blood pressure that she'd seen was 225/123. Now that person was in kidney failure, renal failure, but yeah, that's bad blood pressure. But you might ask, what is bad blood pressure? What should I be afraid of? It depends on who you ask. Like heart association is a good one to ask. Basically, you want to pay the most attention to that lower number, that diastolic pressure right here, the 80. You don't want that to be over 90 for a long period of time. Anybody's going to get startled or work hard and have that lower number be over 90. We're talking about at rest. You're sitting in your happy place. Oh, okay, that's good. If that number is over 90, like for months at a time when you take your blood pressure, that's something you want to pay attention to. You don't want it there long periods of time. Now, I have had students your age with blood pressure issues that they've been wrestling with. And, of course, when you're young, you can handle a lot more than when you're older. But it is something to pay attention to. And some of the main causes of high blood pressure, well, we already talked about weight being an issue. Every pound of fat that we have is an extra 200 plus miles of vessels in your body that your heart has to pump blood through. So that's a big deal. Nicotine is a big deal. Nicotine, now I'm going to add some. Nicotine is a vasoconstrictor. Now I'm going to add some notes to the ones that you have online here. I'm going to put some more online. So just a quick couple of items. So these will come up repeatedly in our class, and so I'm going to mention them here, and they will come up again. But vasoconstrict means to make the center of a tube smaller. So if I've got this tube right here, and I make that center of that tube smaller, I wish I could constrict it so that the center or the lumen here actually physically shrunk in size. Got to move that the right way. Okay. That would be to vasoconstrict. And so if you think about that, if a tube vasoconstricts, now if it's a vessel, now the heart is trying to push the same amount of fluid through a smaller size tube. That's going to increase the pressure in the system. I'm going to put more pressure on the walls of this vessel because the center, the lumen, the center part is smaller, but the heart's still got to push the same amount of fluid through it. That's vasoconstrict. That's the risk of vasoconstriction. Now we're going to talk also about vasodilation. To dilate would mean to make the center of this tube larger, to expand this tube. And if you did that, then you would be pushing the same amount of fluid through a larger opening. And that would relax the pressure on the system. There would be less pressure on the walls of this tube here if the tube were larger and pushing the same amount of fluid through it. So vasoconstrict, make the tube smaller. Vasodilate, make the tube larger. Hopefully that makes sense. Let's see, where am I at? Yes, yeah. So heart sounds. When you put a stethoscope on a person's chest, what are you in fact hearing? Can you actually hear the thump? Does that heart actually beat so hard that you're hearing the thump? No, that's not what you're hearing. You're actually hearing the closure of these valves. Okay? Now, the right side here doesn't have as much pressure because it doesn't have to push blood as far. And so it's characterized by that lub sound. Lub. Okay? And it's a softer, less abrupt sound. But the left side here has to push blood a lot farther throughout the whole body. And so there's more pressure on this side. And so that valve, it has to snap shut harder. And that's characterized by that dup sound. Dup, lub, dup. And it's a sharper, more abrupt sound created because there's more pressure on the left side than there is on the right side. But it is the closure of these valves that actually makes that sound. It's also why this one is a big deal. You might hear the term mitral stenosis. Stenotic tissue is hardened, degenerating tissue. And if this valve gets full of fatty deposits on it and hardened, non-flexible, it won't close as effectively. And it will allow blood to leak back into the atria rather than going out the aorta, which is where it is supposed to go. And so the function of these valves is really, really important. If blood does leak back through a valve, we call that a murmur. You can see that right here. Now, I'm guessing there's a number of you that have heart murmurs in this class. Oftentimes, that's because when you're born, there's an opening, if you will. There's a number of openings between the chambers in the heart because as you're developing inside your mom, you don't want blood going to the right side of the heart because you don't want it going out to the lungs where it's going to sit because your lungs aren't functional yet. So blood can go directly from the right atrium to the left atrium through something called the foramen ovale, the oval opening, and also there's another one between the pulmonary artery and the aorta in case any blood does get into that pulmonary vein. Of course, all those have to close pretty quickly right after birth, but sometimes there's still leakage possible through them. A friend of mine had a stroke and recovered from it well, but he was only in his middle 50s when he had it. And he had it because he had an opening still between the two chambers of his atria from birth that had not closed quite as well as it should have. I mean, he was a distance runner in high school and you know, he was in shape and still had that structure. And it had it his whole life, and it only became a problem later in life. So that's not a problem uncommon to people. But anyway, a murmur is leakage back through that valve. One last thing I wanted to mention. You'll see around Bethel and various places this AED, Automated External Defibrillator, and instructions for using them. These are an item that can be used if somebody is having major cardiac arrest. The arrest means the heart has stopped. And how do you get them going again? Well, you can pop this open and sort of electrically stimulate the heart to start up again. And these have been successfully used here at Bethel. Not on me, I didn't need one, but other faculty members have had total heart failure right in the middle of their workday here at Bethel, and somebody's popped one of these out and saved their lives. So these, when you see that AED sign, that's what they're doing. They're trying to electrically stimulate the heart back to work. Sometimes when there's such a major clot in a vessel, it can so stun the heart that it just quits. And these would stimulate it to get back beating again, if you will. I'm going to finish off this lecture with just an introduction to the vasculature. We're going to deal with this a bit more when I'm able to be in class with you. There's some items specifically that we're going to deal with, but I'm just going to briefly introduce the three vessels that make up the tubing system that is your circulatory system. So we've dealt with the heart, and now we're going to deal with the vessels. We've dealt the heart as the pump, and these structures, the arteries, the veins, and the capillaries, or capillaries if you're from the other side of the pond, are the tubes that carry the blood to and from the tissues. Okay. Now it's important to remember these capillaries are way smaller than this might give you the idea that they are. You have a capillary bed in close proximity right up against every cell in your body, with just a few exceptions. One of those exceptions is something we call cartilage. And if you've ever damaged a cartilage, you might know that it's hard to repair cartilage. Well, part of that is because they don't have a close by system of vessels that connect it to the circulatory system. This will come up again when we get to the skeletal system. But nutrients and waste have to diffuse through tissue to get to the what was I just talking about? To get to the cartilage and then back again. So now some of you can damage cartilage, and your body will actually build a capillary network to the damaged area, which it will dismantle after it feels that it's healed that, which is an incredible thing. So if we look at just quickly at the aspects of those structures, we'll start with the arteries and arterioles. So these would be carrying blood away from the heart to the tissues. And notice it's thicker walled, got a thick muscular wall. This allows it to expand and contract, and the muscle actually allows it to contract or expand on its own to make this hole bigger or smaller and respond to stimuli. And I will demonstrate that when we get to the lab right after spring break. You'll actually feel that. Sometimes your hands just go cold, and that's because you have vasoconstricted. Your body says, I don't want blood going there. I'm going to keep it in my body core, your body core, because you want to maintain heat. So it shuts off blood flow or reduces blood flow to your exterior, to your perimeter, to maintain temperature in your body core. Well, that makes your hands and feet cold. And so that muscle layer helps that to happen. So muscle and elastic so that it can stretch. If you remember, like the tube here, like demonstration. That helps regulate blood pressure, temperature, all those things. Then we have this capillary network. They're tiny. I'll show you a video when we get back after spring break of blood flow through a capillary network. These capillaries are only a small. Some of them, the hole in the middle is even smaller than a red blood cell. And you might say, well, how can a red blood cell get through there? Well, the red blood cell actually sort of what we call tacos over, folds in half like this so that it can squeeze through. And what happens when it does that is it's rubbing up against the side of the capillary all along this edge of the blood cell, and it gives it more contact with that capillary, and that allows for easier exchange of nutrients and waste between the blood cell and the capillary when it's actually touching the wall of that capillary. Only one cell thick. Yep, easy exchange of nutrients and waste. And then right here, notice these little structures here and here and here. There's our word again. Yep, it's more sphincters. Okay, and you've heard this. You know what not to do after you eat a large meal. And if you're close to a swimming pool or a lake, don't go swimming. It's not an old wives' tale. It's the truth. Your body will close off these sphincters So it will close off blood flow to your muscles so that it can send more blood to your digestive tract so that you can more efficiently digest and utilize what you've eaten. But if you try to do something, your muscles aren't going to get enough blood flow and you are more likely to cramp as a result of that. So that is a very true statement. That is accomplished by these little sphincters here. And then lastly, the veins and venules, just basically carrying blood back to the heart. You'll notice they don't have nearly as much muscle, very little muscle, mostly elastic tissue and epithelial tissue that we find there. But down in here, this is trying to represent the fact that there are also valves in veins. And we're going to learn that that's important because it helps veins, it helps the blood in veins not flow the wrong way. We want blood in veins to always be moving towards the heart. We never want blood to sit in one spot. And so these valves keep that blood from backing up. They keep it going one direction. And that's going to be really, really important. And I'm going to try to make the case when after spring break that as blood flow goes through the arteries into these capillary beds and then out the other side, blood pressure just falls right off here. So it's really not that much blood pressure that's causing blood to flow through the veins. It's actually these valves and then movement, skeletal muscle contraction, squeezing on these veins. And just like you would milk a cow, I'm sure you've all done that. You're gonna use your muscles. It'll press in on the vein walls, and that'll reduce the volume in that particular area. It'll squeeze the blood, if you will, and these valves then cause that blood to only flow one direction, and that's as a result of those muscles contracting. Okay, well, we're going to pick it up there when we get done with spring break, and I hope this didn't rattle on too long. You guys have a most excellent time, and we'll see you later.